So now I am really excited to introduce our speaker for this evening, Dr. Joseph Cabaza. Dr. Cabaza is a pulmonologist and a critical care medicine doctor at the Cleveland Clinic. He is also the director of the non-CF bronchiectasis clinic in Cleveland, and he is experts in bronchiectasis and often speaks at conferences and events. So with that, we are very excited to have him attend and to educate us tonight, and I'll let him get started.
Hi, Julie. Thank you very much for the introduction. Thank you, everybody, for joining tonight. It's evening if we're on the East Coast, and probably sun is still up on the West Coast. So thanks, everyone, for tuning in to really my topic near and dear to my heart. Really what I do day in, day out is discuss bronchiectasis. So the title of this talk is Bronchiectasis, Considerations for Diagnosis, Treatment, and Patient Education. All right, and these are my disclosures. Bronchiectasis is a small space, so when you do work in it, you end up collaborating a lot with industry and bouncing ideas and speaking. All right, so the objectives tonight, we want to describe the prevalence data and overlap of bronchiectasis with COPD. Talk about three aspects of bronchiectasis pathophysiology. We'll identify the treatment options and how to utilize airway clearance as preventative care, and implement patient education practices for bronchiectasis. So, whenever I talk about bronchiectasis, regardless of the audience, whether it's pulmonologists or med students or residents, and no exception here with a respiratory crowd, I have to highlight how undertreated we are undertaught we are in pulmonary medical education in terms of the importance of bronchiectasis. So in one of our pulmonary board review books, for the entire pulmonary section, it's 174 pages. Less than 1 page of that is dedicated to bronchiectasis. So that alone in itself would make one feel that this is kind of a rare disease and not terribly common, and perhaps not even that important. And as many of you are out in the field and or in your offices and trying to talk about airway clearance, you may find that there's a real variability in knowledge about an understanding of how the disease is treated, and very different approaches amongst many different providers. When I finished pulmonary fellowship, I knew very little about bronchiectasis because I had no exposure to it. So that lack of training can trickle down very, very quickly into a setting where a lot of patients are getting suboptimal care. And it is rather sad that in our education, we're not taught of it very much. And because of that, it's not thought of enough in the differential of chronic cough and dyspnea. So a very big cause, but we don't really think about it too much. And I think getting that education and learning more about it is going to make us all better healthcare providers in whatever setting we work in. So really, with any bronchiectasis talk, you're going to see a cross-section, an animation of what a normal bronchus looks like and what a bronchiectatic airway looks like. And bronchiectasis is really just an abnormal widening of the airways. When the airways are wide and lose their integrity, the surface of the airways doesn't work as efficiently. Those cilia, these little whiskers on the surface that help sweep up the mucus and bacteria we all make, they don't work as well. And that leads to mucus pooling. And within that mucus is the bacteria we all come across. That bacteria sits down there and causes inflammation, which we'll talk about later. And then that leads to further damage of the cell wall. If this process goes on, patients can develop chronic cough, very often frequent and recurrent pneumonias. And many of the symptoms are nonspecific, which makes this a big challenge. So again, nonspecific symptoms is really a big challenge because they overlap a lot with a lot more common lung conditions such as asthma and COPD. So the most common thing I see in the office in patients coming in with either new diagnoses of bronchiectasis or having come from the community for another opinion, they're often misdiagnosed and treated as asthma or COPD. Those are a lot more common and well-known pulmonary conditions. But however, even when patients are correctly diagnosed, bronchiectasis is identified on imaging, So often these patients are still treated like asthma and COPD, and that generally involves the excessive use and often inappropriate antibiotics as well as systemic steroids. So because it's not in that differential, these patients really fall behind. If you can imagine, if you have a chronic inflammatory condition that's not treated or undertreated, patients are going to use the healthcare system more. There are more hospitalizations, clinic visits, imaging, and laboratory testing. So back in the 80s, when there's a kind of deeper understanding and awareness was starting to increase in bronchiectasis, this cycle here was the hypothesis and felt to be driving the picture, where there's initially an insult. So something happens, I think very commonly in pneumonia, for example, you have a lung infection, and there's inflammation from that insult. And then neutrophils come to the site. These are immune cells that are meant to fight off and kill those bacteria, but those bring with them inflammatory substances that can damage the airways directly. The airways get damaged, the cilia don't work as well, the airway form changes, and then mucus accumulates. Within mucus accumulation, the bacteria colonizes the airways, and then eventually that'll tip over into an infection. And then that cycle will go round and round. And this really is a basic thinking about bronchiectasis, and a lot of aspects of it hold true. But in the last decade or so, as we've kind of developed more understanding of the pathophysiology, you realize it's not so much a cycle where one thing leads to the other. It's more of a vicious vortex where each component or part of the cycle can further worsen every other part there. So you kind of see here, everything is intertwined. When your airways can't clear mucus normally, that'll lead to more neutrophilic inflammation. That'll lead to more infection and bacteria in the airways. That'll lead to more lung destruction. And that applies really for every corner of this vortex that can further feed it. So when you have a cycle, if you stop one part of the cycle, that could significantly slow things down. But in a vortex, as you can see here, if you focus on just one area of that vortex, things can really still progress and keep moving forward in a negative fashion for the patient and their airways. So COPD, very common diagnosis, but it's not uncommon for bronchiectasis to coexist with COPD. So there is an overlap syndrome with bronchiectasis and chronic lung diseases that is starting to get a little bit more attention, and a little more research is coming out on these types of patients. And it's no surprise that patients who have COPD and bronchiectasis are sicker. So the prevalence of bronchiectasis in patients with severe COPD is about 35%. So very common in my COPD patients. On a CT scan, you'll see evidence of bronchiectasis in the airways. And as you can imagine, the more severe COPD is, the more likely they are to have bronchiectasis. But bronchiectasis with COPD patients also, they have more dyspnea, increased risk of exacerbation, and a higher morbidity. For me, one of the red flags in any uncontrolled COPD patient, any COPD patient that keeps having recurrent exacerbations, I need to rule out bronchiectasis or chronic infections if it has not already. Now, other studies have taken a peek at this as well. When you look at patients with COPD plus bronchiectasis compared to patients with COPD alone, those with bronchiectasis had more exacerbations, more pathogenic organisms, so they became colonized with bacteria that can be more harmful and make people sicker. They had lower FEV1, so a more severe phenotype of COPD, and higher mortality. They died at a higher rate, and that makes sense. Having two bad lung conditions is going to be worse than one. Now, back in the CHEST meeting 8 years ago in Los Angeles, this abstract looked at a lot of 855 COPD patients. 362 of them had bronchiectasis. So 42% of patients in this cohort had bronchiectasis. Of those with bronchiectasis, 48% had moderate to severe COPD. And then of those with COPD, 49% had stage 3 disease and 59% stage 4 that had bronchiectasis. So the more advanced COPD patients were more likely to have bronchiectasis as part of their diagnoses and changes in their airways. So COPD patients with bronchiectasis do worse. And what kind of fits with other studies and what we think, 90% of COPD patients in this investigation had 2 or more exacerbations or 1 hospitalization the prior year who had bronchiectasis. Meaning if you have bronchiectasis with COPD, it's hard to stay controlled in terms of flare-ups. Very, very few of these patients actually had a year that didn't have hospitalizations, didn't have flare-ups that required changes in care. So you technically can diagnose bronchiectasis from a chest X-ray, but it's pretty challenging. X-rays don't show a lot of detail. And in fact, chest X-rays in bronchiectasis and chronic lung conditions are oftentimes normal. So the key to diagnosis is getting a CT scan, of course. So again, an X-ray, normal X-ray cannot exclude a diagnosis. So any patient that you have a suspicion of, so really any uncontrolled airway disease, so asthma or COPD that despite all therapy, they keep flaring up, you can't control. Refractory chronic cough, unexplained fatigue and weight loss. If they've only had a chest X-ray that's clear, they need to get a CT chest to really confidently rule out bronchiectasis or bring that diagnosis to the surface. So what is the treatment for bronchiectasis? You can imagine by the vicious vortex, it's not going to be just one treatment, but our goal is to slow down that vortex. We want to optimize the treatment of the underlying cause. So there are a handful of causes of conditions that can cause bronchiectasis that do have treatments for them. So that would be the first start, like autoimmune diseases, for example, or immunodeficiency are just 2 examples of conditions where you would treat those underlying conditions. But for the most part, many patients are idiopathic and they don't really have a treatable etiology of bronchiectasis. So in those settings, when we approach the areas of the vortex, we want antibiotics that target culture results for acute exacerbations and infections. Chronic macrolide and or inhaled antibiotic therapy. Those are ways to approach some of the chronic inflammation. And daily azithromycin is the one we start with if they have more than 2 exacerbations per year. That is really the only anti-inflammatory we have right now. But airway clearance is crucial. It's both therapeutic, it can make patients feel better, but also prophylactic, help prevent flare-ups and exacerbations. And our goal is to kind of slow down the vortex. And again, this is a picture that you want to know very well, and any patient I see with bronchiectasis, I'm envisioning this vortex inside their airways. And we'll kind of zoom in and kind of round the bases here of the vortex, and we'll zoom in on each component. So chronic infection, is one angle. And again, for that, we want antibiotics that target culture results for acute exacerbations and infections. We get tons of sputum cultures in bronchiectasis clinic. We want sputum culture at each visit. We want them if at the first sign of a flare-up at home. We want them even when you're feeling well, periodically throughout the year. The more information we have and understand what the bacteria is that your normal environment in the airways, the better equipped we will be to treat exacerbations by using the appropriate antibiotics, not random antibiotics, but ones targeted specifically to what is showing up in your sputum cultures. Now, then we kind of move over to the neutrophilic inflammation side. As I briefly mentioned earlier, azithromycin is really the main, the only direct anti-inflammatory we have. Azithromycin is an antibiotic, of course, but in this setting, it blocks parts of the neutrophilic inflammation that can occur in the lower airways. So patients who exacerbate frequently, if you put them on daily azithromycin, they'll have less inflammation and ultimately less exacerbation. And a lot of patients may even feel better, just improvement in their daily symptoms. Hopefully soon, within the next year or so, there might be a new targeted anti-inflammatory medication available. So we're kind of excited to have a kind of a more specific option coming up. Now, in terms of bronchiectasis, the lung destruction, when lung destruction occurs, that's going to be irreversible. So chronic infection will lead to inflammation, impaired clearance, and then, bacteria, mucus, inflammatory cells can really build up in focal segments of the airways and cause extensive destruction that's irreversible. So on the left is an example of really distorted airways, a lot of bronchiectasis. We can see scarring, even a small cavity in the left lung there. And then on the right, the slice on the right in that bright mid lung area in the back there you see a really massive cavity. And that right there is a marker, really lung necrosis. I mean, the lung tissue is dying and getting killed by the bacteria. So those are very serious and become very hard to treat and especially cure. And the large cavities like that oftentimes are very hard to cure, and surgery may be the only cure in those settings. But unfortunately, there are a lot of patients who develop that who just don't have adequate lung function to tolerate surgery. So if they're a surgical candidate, cavities can be cured in that way, but that's why trying to catch patients and treat them before it gets to that point is vital. So any cavity, no matter how small, is going to need to keep a close eye on and more aggressive treatment to when it's potentially curable. But when they get as big as the one on the that previous scan, it is going to be a very tough go for the patient. Now, of course, the biggest arrow deals with the airway dysfunction component of the vicious vortex. Again, epithelial dysfunction, mucus hypersecretion, the cilia on the surface don't work as well. That is really the most central thing. So airway clearance is the most important thing to slow down that vortex because it just does so much. As you can imagine, if the airways have mucus in them and bacteria, air is not going to move very well. Inflammatory cells are going to get stuck down there, bacteria stuck down there. So if we can clear those airways and make them look closer to a normal airway, at least on the inside, there's going to be less mucus and secretion. Ventilation is going to improve, and as a result, less airway obstruction. You're going to have less bacteria, and then less acute infections, and ultimately less exacerbations. So I like to think of airway clearance as a form of source control. And if we hone in on that, if we're just doing one thing for patients in bronchiectasis to start with, airway clearance is the very first thing, and then you can kind of reassess the other components. Now, it's important to note that exercise is a form of airway clearance. So some patients with very mild disease, they clear their airways with exercise alone. We recommend 150 minutes of moderate intensity exercise. Just build up a light sweat, something that stimulates deep breathing. And just that air moving quicker across the airways in itself can help loosen up secretions that are stuck in the airways and help provide some moisture in the airways. Pulmonary rehab for those who qualify is crucial. A lot of patients with bronchiectasis have pretty good looking pulmonary function testing. Many of them don't qualify for pulmonary rehab, but those who do, especially the ones who have COPD, they all greatly benefit from that. We use bronchodilators to help open up the airways just a little bit. We then nebulize sodium chloride. So that salt water, that solution gets down deep in the airways. It pulls moisture into the dry mucus. It pulls moisture into the lining in the airways, and the cilia start, the ones that are remaining can start beating a little bit more effectively. Then we use a positive expiratory pressure devices or acapellas to help try to pull that dry mucus off the airways. Those are usually what we start with, and then if people are still not responding, vest therapy, different breathing maneuvers, postural drainage, and percussion all can be beneficial. As many of you know, adherence can be a major issue, but in my experience, patients who understand their disease have far better adherence than those who don't. So I see many patients whose expectations are not explained to them very well, especially patients with bad disease. It can take several weeks, a month, or longer of regular airway clearance to start seeing improvements. If they're not adhering to therapy, their symptoms are going to be worse. They're going to have more exacerbations and keep going down deeper in that vortex. So I find, when patients understand the what airway clearance means, and when they understand how it's removing bacteria, how it'll minimize the odds of them needing antibiotics, of how it'll minimize the length of time they may need antibiotics. I mean, I find adherence to be very, very good in this population, but the key is that they understand their disease and why they're doing it all. So there is no one right regimen or way to approach airway clearance. So each center, each provider is going to be a little bit different, but the key is to start with some base approach and then step up or down from it based on how patients are doing. So our initial treatment approach in Cleveland is we generally start albuterol, either nebulized or through an inhaler twice a day. Again, we want to open the airways up just a little bit, but also it'll help them better tolerate and less likely have bronchospasm when doing sodium chloride neck. So again, that's saline. We think if the airways are open a little bit, it'll get a little bit deeper. Then we have them do an a cappella 20 breaths or so twice a day, followed by some huff coughing. So that is our initial approach. So when I'm needing a new patient starting on airway clearance, this is what we start. And then we'll reassess in 6 weeks or so to kind of see how things are going, how are their symptoms, what are their cultures showing. And then based on that, we will step up or down. If they still have a daily productive cough, despite the initial treatments, which are less expensive and still very effective, then we would very quickly pursue a high frequency chest wall oscillating vest. So, I like to incorporate pop culture into most of my talks, and I'm a not so secret big Bon Jovi fan. And oftentimes when I see patients, especially with bronchiectasis, but the song "Bad Medicine" pops into my head for many reasons. Because oftentimes they're misdiagnosed or treated in suboptimal ways. But the line "Shake It Up" just like bad medicine makes me think about vests always. So if we take away one thing from this talk tonight, I want you at its conclusion to put on bad medicine before you go to bed tonight, just to kind of jot your memories. And for those who don't know it, I think you might get into it. And here's me shaking it up, during COVID, a little break from the ICU, trying on a vest, and I don't have lung disease, and it feels like a nice little massage. It was a relaxing break, but it made me cough from wearing it. And I have normal lungs, and just the normal secretions I'm making are getting moved to my central airways, and that's stimulating cough even in healthy people. Now, if we look back into the history of vests a little bit, they first came out for cystic fibrosis patients. So in the late 80s, they were first released, and they found to improve lung function on PFTs compared to manual chest PT. So that was, it helped save some labor, but also it had an improved benefit in lung function. So they essentially, are essentially wrap around the chest, deliver chest wall oscillations, as well as pressure, and those move secretions from the distal small airways closer to the larger big proximal airways so that then they can be coughed out. And that works even in people with healthy lungs like myself, but really in the CF patient, bronchiectatic patient, they can be extremely beneficial in those who are still struggling despite the initial approaches to airway clearance. There are two different kinds of vests. There's a stationary one, has an electric source. Hoses are attached to a compressor that connect to a vest. Then we have I think the more common and popular mobile ones that are battery operated, so patients are not tethered in. And here a kind of a sneak little pic of two different ones. The one on the left, of course, is portable. She's out on a swing out in the yard, and then the one on the right is stationary, where there's a machine and hoses plugged in, and she can't really move anywhere. But it is a different approach at delivering oscillations outside the chest. So if we are shaking things up outside the chest, the vicious vortex up here, that's going to start slowing down. So we should be having a little bit less neutrophilic inflammation as we can cough up more in the central airways. Should be having a little less bacteria, a little less chronic infection secondarily, and then ultimately with less infection and inflammation in the airways, it should be slowing down and minimizing the irreversible lung destruction and progression of bronchiectasis. And this is Dr. Bazavaraj, who's one of the big bronchiectasis docs out in NYU. We work with quite often, and has a really big interest in airway clearance and the modalities, and has a lot of really interesting studies looking at things. But he had one big study on vests and looked at their outcomes, and it was really what he found was really kind of made sense. People who used vests in addition with their airway clearance, generally were sicker people, but when adding vests, they had 66% less exacerbations and hospitalizations compared to those who were not using vests. 46% decrease in the need of IV antibiotics, 9% decrease oral antibiotics, and 10% less physician office visits. Now, IV antibiotics, when patients need them, it's usually not just a couple days in the hospital. Usually they're sent home with an IV in their arm and can be on them for several weeks at home. So decreasing IV antibiotics is really a big deal and really important for quality of life for patients. A separate study had very similar findings of just less hospitalizations when vest was used in non-CF bronchiectasis, less antibiotics, and patients felt that they could clear their lungs better. Even at 1 month, the benefits were sustained 1 year out for all of those. So these were not just short-lived benefits, they were maintained long-term, which it makes sense. Because if you're coughing up more stuff, you should long-term, and you're consistently doing it, long-term you should have less inflammation and feel better overall. Now, the advantages of mobile vests, and that's generally what I start with, due to the advantages, there's less equipment. Patients with bronchiectasis generally have a lot of equipment to begin with, between different inhalers and spacers and nebulizers and acapellas. So they really prefer often to have less equipment. They can complete other activities while wearing the vest. So for some patients, especially younger ones, that can be an attractive feature. But even if you're not moving around during treatment, some people just like not feeling tethered in to equipment, even if they're just going to be sitting down while using the vest. And so ultimately, they're more likely to adhere. And adherence is key in bronchiectasis and airway clearance. Whatever a patient can and is willing to do is what is best for them. So if they're more likely to adhere, the vortex is more likely to slow down, antibiotics become more effective, they ultimately will need less antibiotics, and they have improved symptoms and quality of life. But now when we kind of dive back into bad medicine, which was usually my first thought, is when people are on treatments that are actually harmful to them. Now, these two treatments are antimuscarinic antagonists, so ipratropium, tiotropium. These are very common medications used in COPD and asthma. And they have an appropriate role in those conditions, but in pure bronchiectasis, they actually can be harmful. And that's kind of the bad medicine. That's when the initial keyboard starts going through my head of the song Bad Medicine, because antimuscarinic antagonists can dry out secretions, making it harder to cough them up. We like to reserve those class of medication for those with COPD who have showed a need for medications from this class. So when I get a new referral with a patient on these medications, my first move is to stop the medication and see, do they feel worse off of it? I'll do this in conjunction with intensifying airway clearance. But if I'm only allowing them on one of those medications, if they're saying, hey, I feel better when I'm on this medication, then it's okay in that setting, because everything is risk versus benefit. But I will say the vast majority of patients that I stop those medicines in are not restarted on them at all. So inhaled corticosteroids are very big in asthma, also select patients with COPD, but they should not be part of a baseline therapy in bronchiectasis. Inhaled steroids are a form of immune suppression locally to the lungs. So people on inhaled corticosteroids are more likely to develop lung infections, especially non-tuberculous mycobacteria. And these have been studied, and it also kind of just makes sense intuitively. If you're lowering the immune system in the lungs, more likely to have bacteria grow further in the lungs. And people with asthma also don't clear bacteria as effectively and normally, so they're going to be at risk. But here I'm talking about the non-asthmatic bronchiectasis patient who's placed on this just because they still have shortness of breath and symptoms. So again, we reserve those who have asthma and bronchiectasis. And just like with the antimuscarinic antagonists, I will stop or minimize inhaled corticosteroids in patients and try to make them prove to me whether they need that class of medication or not. Because if really what those medicines do, they feed the vortex. So chronic infection will increase. I should have made kind of bigger green arrows going out of chronic infection when people are on inhaled corticosteroids, bigger blue arrows outside of the airway dysfunction part of the vortex, because when people are on antimuscarinic antagonists, those are things that feed the vortex and can really speed it up. So important to be aware of those medications, and especially in patients who are uncontrolled. Um, so another, and I think kind of lastly of the harmful treatments that I see, I still see, although not as often, a week of alternating oral antibiotics every month. So I'll see some patients who say, I was told on, January to take azithromycin for a week, and February augmentin for a week, and March doxycycline for a week, and then repeat that cycle, some combination of that. It's a very outdated practice. There's no evidence suggesting any benefit, but you're developing risk of resistance and potential side effects of being on that many antibiotics, including C. diff. So we really like to have our antibiotics being targeted, and that's why we get frequent sputum cultures. So we're always up to date on the most recent isolates we should focus on and their most recent antibiotic susceptibilities. There certainly are many challenges, I think, in this space. And how do we educate pulmonologists? And again, I was one of those pulmonologists. I came out of pulmonary training really having zero understanding of bronchiectasis. I mean, I kind of did lump it in to asthma and just didn't really have a great approach on how to think about it. But I think recognizing bronchiectasis and understanding the vortex is so vital for anyone in the pulmonary space. Assessing the airway clearance needs, that's a skill that, again, unless you're at a center that has bronchiectasis in your training, it's going to be hard to develop a streamlined approach for that. And then also, adding vests sooner. That's something we commonly see of patients struggling for years with inadequate airway clearance, despite what they're on. And a vest is not added when they're sent to me for an additional opinion. And the sooner we intensify airway clearance in symptomatic, uncontrolled bronchiectasis patients, the better they're going to do. So in terms of recognizing the bronchiectasis, again, I emphasize often chronic cough, uncontrolled asthma, and COPD, they need an updated CT scan. Even if the X-ray is clear, because we need to understand what's happening in the airway before we go down other routes. So chronic cough, for example, oftentimes is neurogenic. We treat the nerves of the cough receptors. But you really want to make sure that the lungs are clear of bronchiectasis and chronic infection as a cause, because then the treatment of neurogenic cough becomes less effective. So don't let a clear X-ray have you move down that path and away from lung disease. Uncontrolled asthma and COPD, as we spoke earlier, if you're having recurrent flare-ups, daily symptoms, frequent steroids, antibiotics due to asthma and COPD, need a CT scan to see, is this really bronchiectasis with chronic infection? So what we do with assessing airway clearance needs, I mean, we call each patient after culture results between visits, because we get lots of cultures to assess their symptoms and airway clearance. So we get back a culture, saw somebody a couple months ago, and then they left a culture and it's starting to grow an organism. We call them, say, hey, how are you feeling? They say, well, I'm fine, I'm at baseline, then good. We just continue to monitor, and we've got a fresh sputum culture that we would use to guide our antibiotics should they exacerbate down the road. But if they say, the last week or two, I've been feeling a little worse, I'm a little fatigued, cough is increasing, well, then we depend on severity of symptoms. We either increase the frequency of their airway clearance, or we will increase frequency and then later add antibiotics depending on how they're doing. So how do we educate patients? Because that in itself is just as important because, again, an educated patient is an adherent patient. And a patient who has good knowledge and is able to control their disease and symptoms and start an action plan before even reaching out for you. So I always try to make sure every patient understands the vortex. I pull out that picture in the office, um, and really that helps them not only understand their disease, but helps understand the rationale of airway clearance and how it could take weeks, if not longer, to start seeing results, but also understand if you don't see results, that's okay because it's probably decreasing the odds of bacteria, infections, and exacerbations. It's therapeutic and preventative. And again, diligent therapy is needed, and it can take several weeks to see the results of that. So just them understanding that really increases adherence. Um, Now, from the DME side, I think we have to remember, physicians are, they're kind of two customers, but, the physician customer service is vital. Anything that decreases calls, clicks, and paperwork for us is going to catch our attention, and we tend to gravitate towards DMEs that make things as easy as possible for us because it's, between everything we do, the amount of time and clicks and call, I mean, anything that seems to slow us down a little bit will be, will kind of drift away from. So anything that can offload our office, from insurance matters, when that's handled, I mean, that is a huge relief on our staff. Providing social work and case management for a DME is extremely helpful when we're working with them, and really rapidly responsive rep to all questions. Patients certainly will have issues with their equipment. And when patients are directed to call me when they have issues with their equipment by their DME, that's generally concerning to me because I don't know much about equipment, and I rely on a good DME to help with the patients on that side. So these are all kind of very things to think about, and kind of what we kind of gravitate towards are, who's making my life easier and offloading my office, and ultimately that leads to making patients' lives better. But the patient is the other customer, and the most important customer. And I think having a regular respiratory therapist patient relationship is vital. I mean, I've got many patients who like talk to me about their respiratory therapist as if they're part of our healthcare team and part of their team, and they really are. And when that's happening, that tells me that the patient's in a really good setup. Having people in their circle that they can trust, and having an RT regularly on call that can troubleshoot equipment issues. Because again, our offices, we're not really on top of how to handle equipment issues. So if we have responsive respiratory therapists on the ground that patients trust, that's going to be a highly desirable setup in DME from our side. I can't tell you the number of my patients who talk about their respiratory therapist, who sees them, who's not part of the Cleveland Clinic, who they view as just a super valuable part of their team, as they really are. There's nothing more important than a really good respiratory therapist. When the respiratory therapist incentives line up with what's best for the patient, then I think everybody wins. And because ultimately, yeah, sure, we want the office, offload, time and work in the office setting for us, but really nothing's more important than having the patient being satisfied and saying, and just feeling really well taken care of, both by their team in the office, but also by their team on the ground at home, the respiratory therapists. Now, so as part of the education we do, so in the office, I will talk for a long time with patients and educate within that office visit, but it can be overwhelming. So always after that office visit, I send them videos and tools to watch at home with their families, because educated families also lead to better patient care. So Impact is the site and link I use most often when I send patients. Like, it's got lots of great videos, very simple, short videos that are easy to grasp, and it really helps patients further understand why they're doing what we're suggesting from an airway clearance standpoint. So that this site again is super valuable. I've got a dot phrase on Epic, so I just type in dot impact, and then all these links and videos spit out to the patient's chart, and they're able to click and watch at home. And then usually that may generate some questions, but for the most part, they end up saying, yeah, that was really helpful. And here are some of the screens. Here's the website, and it's great. They have videos on short video on bronchodilators, hypertonic saline, mucolytics, really everything we use. But also has videos on how to incorporate airway clearance to a busy day, how to approach airway clearance when going on vacation. So very practical, helpful stuff here. And the video library again has so much great content throughout. So I send them the videos to watch of the specific components of airway clearance that I will be having them on. All right, so we made it to the summary slide. I think we're okay on time. So I think bronchiectasis is underdiagnosed. That's a big thing, but also when diagnosed, bronchiectasis is often undertreated or incorrectly treated. So usually treated as asthma or COPD. We talked about some of the bad medicine, how those treatments can actually be harmful in bronchiectatic patients. Many COPD patients also have bronchiectasis. So COPD plus bronchiectasis patients generally are sicker and do worse. So important to recognize it in our COPD patients and not just assume all their issues are due to COPD and treat them accordingly because they'll need more than just COPD therapy. And the treatment of bronchiectasis really focuses on addressing the components of the vicious vortex. Patient education is paramount. An educated, well-informed patient is going to be very adherent and go far. Many providers don't have the education themselves to pass on to the patients, and I was one of them. So having an informed respiratory therapist add the education to the patient can be invaluable. Airway clearance is crucial. We use anti-inflammatories when appropriate, targeted antibiotics based on frequent sputum cultures, and then surgery may be needed for those who are candidate in structural disease if all else fails. And we've made it to the end of the slide. I always end with, I just always thought this was a cool picture of the lungs. And all right, and then I think this is for you, this last slide here. So I'm happy to take any questions.
Thank you. Thank you. Thank you so much, Dr. Kabaza. This was wonderful. Such great information and education for all of the attendees. So to receive your certificate, you must really complete the course evaluation. Once the program is complete, you'll be redirected to the course eval. And in addition, all attendees will receive a follow-up email tomorrow morning with the link for your review and your records. So I have a question. And first of all, I think it's fantastic that you play such an active role in educating your patients because patients don't want to not be adherent to treatment. And I think so much of education to patients is going to result in either an adherent program or a patient that just doesn't understand enough about their chronic disease, or they haven't been informed enough to understand the why.
Yeah, I think, before I got into bronchiectasis, bronchiectatic patients were kind of billed to me as a very high maintenance group because they're non-compliant and difficult. And I found the complete opposite, once I've gotten into it. They just don't understand their disease. And I would argue that an educated bronchiectatic patient is a very compliant patient. And so the more education they have, the easier my job is, the easier our office visits are, and things kind of flow better. So it's a win-win for everyone, but especially the patient.
Absolutely. And it's really good for, I think, the attendees to hear that today, just to continue that education to provide additional resources for your patients. I'm also curious, obviously there is a huge gap in education for physicians with around bronchiectasis. How did you get involved, so passionate about it? Was it a colleague of yours? Was it patients? And not only that, but also in addition to, your speaking, how else can we educate
Yeah, it's kind
physicians on this condition?
my story is kind of long, but I'm not good at being brief, but I'll try to sum it up. I just randomly became very good friends with the head of our bronchiectasis program, signing out to him in the ICU one night. We were just talking. We ended up kind of talking about sport. I mean, we just really hit it off. Turned out we lived in the same town, and we became friends very quickly. And he was the director of our bronchiectasis program at the time. So a good friend ultimately, became a mentor in that I would start running patients by him that I was had with bronchiectasis, and kind of quickly realizing how wrong I was in my thinking and approach by kind of discussing cases with him, and that kind of inspired me to take better care of them. And instead of sending them to the bronchiectasis clinic, I would just run it by him and then manage my patients based on those recommendations. Then it just kind of evolved into a passion, seeing how much of a difference I could make in this space because of just how much need there was from the patient side. So that's kind of the short version of it. I randomly became good friends with our old bronchiectasis director, and with time kind of got pulled in. Um, yeah, so yeah, education is that's the big question. I think a lot of physicians, especially, are not excited about learning new material, and how do you kind of get them to change ways, and it can be very hard. But what I found from speaking all over and being in so many different offices around the country, I found, I mean, pulmonary fellows I think are very eager to learn because they're soon to be in the real world and practice and really want to take in anything they can. But I think advanced practice providers, so NPs and PAs,
Yeah.
are very hungry and eager to learn. And in so much of the country, they're kind of running most of the pulmonary clinics. There's the pulmonologist who might be in the hospital, but most of the clinical outpatient duty falls on them. And I found them to be very eager and open to learn. And I think kind of educating the people who are kind of most hands-on, so fellows and APPs can have I think a very valuable trickle down of that, because eventually, I mean, that's, these fellows, when they graduate, will be working in other areas and take those knowledge with them. So I think those are the where I think education can be done most efficiently, because it's very hard to just find the doc, and just randomly try to teach them new things if they're not open to it or recognize any deficiencies.
Yeah, well, that's fantastic. I think the APPs and in almost every setting are really playing a huge role now in active hands-on patient care, which they're really the ones, the frontline workers that do most of the from start to finish with the patient's care, I think, in a lot of these clinics. So a couple questions in the Q&A. Can you, and I think you did talk a little bit about this, can you have a positive CT without symptoms?
Yeah, there are many patients. I mean, it's a very common referral we get, a CT done for another reason. So a lot of people are getting cardiac CTs for calcium scores. That captures a lot of the lungs. And not uncommonly, it'll incidentally show bronchiectasis in a lobe, and that'll be a pulmonary referral. So yeah, we see a lot of asymptomatic incidental findings on CT. You need a lot of lung destruction before symptoms can develop for a lot of people. So catching them when they're asymptomatic is very valuable, but yeah, not uncommon at all.
I know you talked a lot about the irreversibility of the condition at some point in the disease state. So what are some of those really early indications that it is irreversible?
Yeah, well, we're starting to find there are probably phases in the evolution, along the vortex where something can start as just inflammation in the airways without tissue change. And some of those people, it's just, a slight cough or just, mild respiratory symptoms or kind of recurrent mild flare-ups. And if you start anti-inflammatory earlier in airway clearance, some of these people's CT scans then normalize. If it's just kind of ground glass or just looks like inflammation before you have the structural changes. But once you have the airways stretched out, that's irreversible. And if it's diffused throughout the airways, it can be hard to fully resolve symptoms, but it just starts with airway clear. I mean, again, I mean, airway clearance is the main thing. I mean, the symptoms, any respiratory symptom can be a result, but weight loss, fatigue, low appetite, these are things that sometimes in elderly people we might see more where they may not have respiratory symptoms, but then you get a CT and it shows chronic findings. So every patient
Okay.
is so different in how they present and behave. But the earlier something's identified in someone symptomatic, I mean, there's the potential to reverse the inflammatory parts before the inflammatory parts become, irreversibly changed.
So that first indication is that widening of the airway.
Um, yeah, I mean, widening of the airway is how you diagnose bronchiectasis. Yeah, you have to see a widened airway, but before the airway is widened in some people, or many, I mean, it may just be the appearance of inflammation on a CT scan
On the
or
CT. Okay.
so. But yeah, but usually, yeah, I mean, you get a CT, airways are going to be dilated, and then you just have to
Mm,
apply to the clinical picture.
okay. If part of the issue with bronchiectasis is the widening of the airway, then why is bronchodilation helpful if it is strictly to prevent bronchospasm when given the hypertonic saline, or are there more benefits
Yeah,
or
that's a good
reasons?
question. In bronchiectasis, it's the large airways that are widened. So the bronchi, not the tiny, they kind of branch down into tinier and tinier airways. So yeah, the bronchodilator won't, widen a bronchi, but they kind of get down to although it could relax muscle there a little bit, but we're trying to get better airflow in kind of the smaller airways where secretions and mucus might be stuck in. So if we can open some smaller airways that are very distal, that might help saline get down better, and then ultimately eventually start moving that stuff upwards. But this is all hypothetical, theoretical, so there's no real data or evidence that shows that does anything or that it's necessary really at all. Like in so much of bronchiectasis, there's very little data. A lot of it is just we use our clinical experience. And so, yeah, so there are many bronchiectasis. In fact, out at NYU, they don't use bronchodilator before sodium chloride. So again, there's no right or wrong really in the approach at all. But in sicker patients, we generally do throw that in, but there's no hard data that a bronchodilator is necessary as part of airway clearance. But many of us do use it situationally. But we usually start with a bit. We've had kind of people tolerate it pretty well, and theoretically we think that there's a mechanism where it might help enhance the other steps of airway clearance.
Thank you. So this question is, do you provide airway clearance for patients who have focal post-infection bronchiectasis or only patients whose bronchiectasis is more diffuse?
It's really for anyone who's symptomatic and who has scans that suggest mucoid impaction. So there are people with diffuse bronchiectasis who don't have symptoms, and their CT scan doesn't show much mucus. They don't flare up. That's somebody you might just say, hey, let's just do exercise for airway clearance. I mean, just you tell them focus on exercise, but if they start flaring up or start having issues or mucus or symptoms, pneumonias, then you'd start something regular. So we oftentimes will see people with really abnormal CT scans, but they haven't had a pneumonia in like 10 years. And they were just referred because it was found incidentally. So those we kind of just step back, we educate, we emphasize good exercise and educate on the disease. And we might see them once a year. But yeah, we treat the focal patient the same as really diffuse patient. Really very, very similar. Post-infectious, even a post-infectious, a lot of times is, well, at least COVID is giving us a new wave of post-infectious bronchiectasis. That's a little bit more of a diffuse picture than post-infectious pneumonia bronchiectasis, which tends to be more lobar or focal. But we are, especially post those first 2 years of COVID, where we had lots of
Yeah.
ARDS and lung inflammation. That is this most latest wave of bronchiectasis and a little bit more diffuse in those people. Yeah, but we handle them all the same, regardless of what the scan looks like. What are they doing clinically in terms of symptoms
Okay.
and flare-ups?
I think we have time for one more question. What advice do you have for other pulmonologists as new meds become available next year for bronchiectasis patients?
What advice for pulmonology?
Or other pulmonologists, there's new medication coming.
It's with the new medicine coming, I might even end up being overused for the
Oh,
for reason to not having an understanding of the step up and vortex and all that, and like you're saying like the asymptomatic patient with a scan that shows bronchiectasis. A lot of these people might be getting put on medicine just because they have a diagnosis of bronchiectasis, and it's just really, I mean, I wish there was a way I could effectively educate, to kind of, because I was one of these pulmonologists, so it's not a knock on them. We just didn't get in our training for the most part. But understanding the vortex and airway clearance, I mean, those are the central foundation before really reaching, for a lot of people, before going down the anti-inflammatory route, and you got to see how they do on airway clearance, before going down those routes. So if you don't have a strong foundation, it's going to be hard to have a good stepwise fashion of when to step up and add some of these newer therapies. There's other stuff in the pipeline too, but we're feeling very close. But again, it's multifaceted, the approach. So you got to do multiple things, and you have to do good airway clearance before getting to an anti-inflammatory in a lot of cases. So it's hard to give good advice, but just learn
it
more
kind of
about
goes back to
bronchiectasis.
the beginning, right? Like you
Yeah.
need to educate yourself on the disease state and how to diagnose it, how to look for the signs and symptoms, and when to get the CT scan.
Yeah, and I'm hoping, I think, and I suspect there'll be a really good education campaign from the company once the new drug is out. So getting disease state awareness talks, I'm sure, all around, and starting by attending one of those, because I imagine it's going to be an aggressive education campaign,
That would
because
be
a lot of it's
fantastic.
needed.
Okay, I think we are at the top of the hour, so I can't thank you enough. This was really great information, and we really appreciate you taking the time to come and talk to us tonight. Um, and I think that there was a link that was shown at the end here. So some of the questions we didn't get into, but I apologize for that. There were just
Oh,
too many to manage.
wow. Yeah, I just scrolled down a lot of good ones. Um, but yeah, I like Eddie Stoyles though about why is bad medicine what you need, and
I know I saw
yeah,
that.
that's a good question. I could spend a lot of time talking about bad medicine and Bon Jovi. And just so everybody knows, there's a acoustic slow version of Bad Medicine they put on one of their remix albums. That's a very interesting twist on the upbeat rock song. So I would try that out tonight.
Sounds good. All right. Thank you so much,
All
Dr.
right. Thanks,
Kabaza.
everyone. Have a good night.
You too.